Now, the next item on our agenda is public comment. Is there any public that would like to comment? Seeing none, we have, the next thing is task force member and comment and feedback. Any initial comments or feedback? All right. Item number 4, now we'd like to have a discussion of the testimony that we've heard so far at our various meetings by the different subject experts. And then next we'll talk about the Michigan Lead Poisoning Elimination Board report, which hopefully you all had a chance to go through. There's definitely some interesting, I like how they call it a roadmap of good suggestions, and it'd be great if we could put everything into practice. It seems a little overwhelming, and but yeah, I'd love to hear your thoughts on that. And maybe Adam, you want to highlight some items of that, or?
Well, actually, we have a task force member here who was on the governor's task force. Mm-hmm. So, Mr. Hahn might be the best to kind of walk us through the work of the task force at the state level and the recommendations contained in that report.
Sure. I'm not going to read all 103 recommendations, so it reminded me of when the Flint Water Task Force made the recommendations. They had the same, large number. Here's a couple things that I'd say about it. Really, an overview. It's probably the overview of this report that's as important as the recommendations. I think the first thing I'd point out is Emily correctly noted is that we really do think of this as a roadmap. These recommendations are something that can guide our work in the future. The work was designed to be a guide for the state of Michigan partners, but really looking at what the state can do. And then when the group was convened, the lieutenant governor was very clear from the first meeting and at every subsequent meeting that what we're working on here are a set of aspirations, right? So recommendations that are aspirational. So there was a call to really withhold judgment about them, but just simply to put out there aspirations that if there were no barriers, what would we like to see? So as recommendations in that spirit, I mean, they are truly aspirational. The group recognizes that some of them are fraught with potential challenges. Page 9 of the report, gone to this numerous times now, has a little I was going to say infographic. It's not even an infographic. A little chart talks about primary prevention versus secondary prevention. This is clearly something that came out of probably the leading time shift that came out of the commission, was that we need to start thinking about childhood lead poisoning not as something that we only want to deal with through secondary prevention, meaning preventing reoccurrence, but it's something we want to get out in front of. If I would add another row to this, I would add a row that says secondary prevention chases the ball, and primary prevention gets out in front of the ball, or maybe the bottom row talks about that, chases the problem versus stops the problem. And the real distinction being that if we're focused on primary prevention, what we're really focusing on is the exposure that kids have in the first place. And not simply using kids as the proverbial or the literal canary in the coal mine, and waiting for them to be poisoned and then chasing down exposure sources based upon what kids experience, but trying to get out in front of that. You can read that chart. It's just clearly looks at primary prevention as a preferred strategy. Maybe go back then a few pages. I think it's important to look at who was on this group. The commission, or the board itself, was fairly small, but it did have a number of department designees and a ton of support from administration staff. So if you're not familiar with some of the names, Dr. Mona Hanna-Atisha, being the pediatrician that was actively involved in the Flint, the uncovering of the Flint water crisis from Hurley Hospital. Dr. Abdul El Sayed, I don't know if Adam had a chance to meet his colleague there, but clearly a notable new face in the public. and very, what do you want to say, creative and aggressive health director down in the city of Detroit. We had a rep, Riley Alley, from the Great Start Collaborative in St. Clair County. We have a similar group here, but so those groups were represented. Our Mayor Rosalind Bliss, the Ecology Center, that's been working on lead and other toxins for a long time in Michigan, issuing some pretty important reports for the state of Michigan, and Dr. Lake Thompson from Wayne State. You had numerous departments represented, including community health, including DEQ, including MISHTA. And then, again, at this page 4, you see quite a few staff from the administration, which is extremely helpful in the process. Other than that, there's quite a few pages of introductory comments, and then on page 13, you get the first of 4 areas in which the recommendations were made. Recommendations were made in the area of testing children for elevated lead, follow-up monitoring and services. So it's really part and parcel of what the Michigan Department of Community Health and local public health does currently. Oftentimes when you talk to folks who work in those departments, it's the first thing out of their mouth is kids lead poison, we respond. And so that's, and we make sure that we test kids and we respond. And so there's a number of recommendations for that area. They are organized in terms of the recommendations that were asked for specifically in the executive order, and then there are additional recommendations listed after those. On page 18, you get the second area of concern, environmental lead monitoring and investigations. So how do we know that it's in the environment? We heard Catherine Phelps talk about that. On page 23, the next section, remediation and abatement. What do we do when we find it? And I will tell you that this group did talk about lead in all mediums. So it spent little time on water because the Flint Water Interagency Coordinating Council, a lot of work in that area, but it looked at air, looked at soil, looked at paint in homes, looked at consumer products, and has recommendations at all those levels. Clearly, though, like this group has recognized the importance of paint and dust in the home. And then lastly, on page 30, there was a set of recommendations around data and dashboards, or dashboards and reporting. How do we know that we're making progress? And so a set of recommendations there. Subcommittees, the group met for 6 months, June through October, basically, meeting every other week, some meetings in between time to develop these recommendations. And then presented them to the governor in November. The response to that has been the publishing of the report, and then the governor took one of the recommendations in the conclusion about appointing a permanent commission seriously, and has since done that. Here's the real interesting note. The new commission is not the Child Lead Poisoning Elimination Commission. It's the Child Lead Exposure Elimination Commission. So already taking seriously that call to primary prevention, so that new commission will focus on reducing sources of exposure as its primary focus, poisoning being a part of that. Mm-hmm. So I really don't want to get into going over 103 recommendations. I think that's probably more for us to maybe discuss, and for members here to maybe pull forth some things that they think are most meaningful for this group.
Thank you very much. Does anyone else have any thoughts or comments on, either how this report is broken down, or discuss some of the recommendations that you thought would, work in Kent County, or? Somebody have oh, sorry.
I wondered how Kent County compares to the state in a lot of the current situations.
So there's different data. The state, historically has looked at surveillance data for children's lead in children. Kent County has about 10% of the kids statewide that have elevated blood lead levels. We clearly have hot spots, depending on how you look at the data. They rise to the top or near the top. Certain zip codes is currently how the state aggregates that data. The state used to talk in terms of 14 target communities, of which Grand Rapids is one. Now they talk a little bit more in terms of zip codes.
So, talking about Paul's primary prevention versus secondary prevention, I think one of the things the county has done an incredible job of over the years is talking about prevention, like prevention initiative, and the amount of funding, and understanding like the need to move upstream in how we think and respond to some of these types of situations. So when I think what I've learned and through this report or whatnot is that work that Gustavo did and showed us where the elevated blood levels were at, to me it speaks of a heat map, right? In these parts of our community, there are significant issues in those areas. So whether there's a child exposed to lead there in response, or we go in and try to remedy the problem ahead of time, we kind of know where there's hot spots. And using the big data that we have, we could target into this primary prevention. But the other thing that really I've heard, it's been clear to me, is that ROI is really important. Like some of the water changing over all the pipes and things like that, it seems like a very high costs, and it should be done over time, but there's the amount of, it doesn't seem to get the lead for dust, paint, some of these like household things. And I think when I think about ROI, the easier things that we can do, the less costly things that keep kids from getting large exposures. And when I think about the water situation in Flint, a lot of that had to do with the change in how they treated the water, where the water was coming from, things like that, that we're not faced with in the same way here. So I would like to see us focus more on, as in our recommendations that we create, really include that ROI part. And then the thing that we still need to figure out of how to put all this together is, we know where there's pockets of lead challenges in our community, but I don't think we have a grasp on all of the financial resources that we could target at those places. And so I know Grand Rapids, Wyoming, Kent County, some of the nonprofit advocates have been talking about funding that the state may have available. So I think bringing that to light would be helpful. To talk about our community development block loan programs that each of us have that might be eligible to help out. But if we started to overlay those resources with the hot spots, talk about pay for success, social impact bonds, things like that, and we're more proactive in moving to the hot spots with community-based groups, I feel like we would then move the response more towards this primary prevention model instead of the responsive, we have to wait till somebody's tested and then we'll intervene. And I don't know what that means necessarily for some of the funding resources that we may have available, because they might be dependent on an elevated blood level. But I at least would like us to think through what are the opportunities to change that, or how do we maybe think about it differently so that we could get ahead of the problem. Because when I saw those maps, a number of those homes are probably rental homes in those areas. People are going to live in those homes over the years. And so if one child's exposed and they end up moving in 18 months, very easily another set of children could be exposed in that same house. And so unless we get ahead of that, we're going to continue to see elevated blood levels, I would imagine, in those general areas. So that's kind of where my head's in all this. I think I've learned a lot, and I think it's been helpful. But as I read through the report, those were the things that, for me, in terms of how do we move forward.
Yeah, I think that's something that we discussed early on, is that it's going to be important during this process that we create some kind of an inventory of what's happening now, what's available now in the community. We haven't gotten to that stage yet, but I think unless the task force thinks otherwise, I think we probably need to put that question forward to and start putting that list together.
Adam, I thought there was a point in our future agendas where we were going to have some folks come forward. For example, Doug Steck from the city of Grand Rapids to talk about the programs that we're running in Grand Rapids currently and how they operate, so that you had some base knowledge of things that are occurring. So I'm not sure where we're at in terms of if we're still planning to do that, but I have him come in and talk about programs that we're operating.
That program with its 10-year history also has a ton of lessons learned. I mean, it's certainly doing good work, but it's also a huge laboratory for, you know, what works and what doesn't work.
It also
It too
addresses,
is-
I think, some of Matthew's ideas. I mean, because we currently have housing rehabilitation program that uses CDBG dollars. We have the lead grant funds specifically to address lead hazards, and how we layer those programs and funding to maximize the resources that we have. And we also have a partnership with with a lending institution in our community to access other resources too when it comes to rehab loans. So I guess maybe just looking at an example of programs, not just ours, but whether it's Wyoming, Kent County, whomever, to see what we're doing.
Yeah, so, sorry.
Oh, do you know how well people are using those programs? Is the fund available? Does it get used up?
It varies from year to year in terms of whether it gets used up or not. You know, some years, especially when it comes to our housing rehabilitation program, I would say it was slower in some previous years because you know, people had a lot of concerns with the foreclosure crisis of investing in their homes. And it is an investment, so it slowed down, but things are picking back up again, of course. So that it varies, and we're getting ready right now to big sort of blast of information, in particular regarding both programs, our homeowner rehab and our lead hazard control program.
So back in December and January, when we put the timeline together for the different topics that we wanted to
Right.
address.
I just don't remember when that
Yeah,
was.
so we
So
kind
it was
of
this month.
last month's meeting, we kind of decided that we wanted to take this month to kind of reconvene, talk about, see if that was still, excuse me, the course forward we wanted to take, or were there different or less or more different further areas of concern or question that we wanted to have addressed. I think it's probably a good idea that we do gather that list and bring in some of those experts, some of those leaders in the community that can talk to us about what's happening now. The other area that we have remaining is the state and this report. And after the state budget being proposed, we wanted to hear from someone at either the governor's office or someone at the highest executive level to come and talk to us about what's the plan at their level to activate these recommendations.
In July, not in our June meeting, but in the July meeting, Lieutenant Governor Calley is available during that time, so we could have him address that.
That'd be terrific.
Yeah, there's a transition period. The current board, which actually continues to serve until October, it was an 18-month appointment. But that board's going to be sunset, and so there's some overlap with the new commission. They are having some joint meetings. Hard to know, still working on schedules, but probably by that date should have those completed. And so, and should have begun prioritizing what's in this report, so we can, instead of looking at 103, we can look at the ones that group's beginning to identify as the most opportunities for action in the near future. So that may be good timing. Might be a little tight, but should be.
Yeah, for me, a couple of observations and perhaps a question. One of the things that really struck me at the beginning of this process was our discussion about how there was a period of time that we saw this increase in numbers of children with the concerns with lead. But I never felt that we really answered the why to that. The number of property based upon age hasn't changed. So I'm still questioning the why. One other thing that struck me in the presentations was the discussion about we have had a growth of refugee population, resettlement, migrant populations into the West Michigan area, and in particular the city of Wyoming, which of course resonates with myself. And there was discussion by particularly one presenter that the level and the rates of lead exposure and toxicity in perhaps their homes is something that we need to be cognizant of. So I keep asking myself, is there a correlation there if we've seen an increase in resettlement, that's also having an effect upon our numbers? Because did we answer that question? Does anyone else feel that we answered the question of the why? So that seems to me.
Speculations.
Yeah, because I wrote down, we've talked about physical structures. We said that, we're not in the same place that Flint was in. Most of our communities have addressed the lead pipes in a proactive way. So are we was it an anomaly? Was it just exposure to testing that caused that? So they were always there, but we just never identified that because there was more money through Medicaid for testing or something, or was there the other causal effect? In part, some of those transitions in our economy with resettlement or immigrant, and do we have to work with our team members of Catholic Social Services or Bethany to say how are they partners for identifying persons who may be at risk? Just a thought.
Those are great
Any
questions.
thoughts?
Yeah. So-
Any thoughts to that?
I could agree more answering the question why we saw that blip in 2015 is really important. Still don't know. I mean, we've ruled out a few things. Water's been pretty much ruled out, or has been ruled out, and who's doing the testing and what lab is doing the analysis largely been ruled out. It's not one particular provider, one particular lab. So those things have been kind of cleared, and those kind of low-hanging fruit.
I think in our
Continue to look at
conversations,
housing,
we
continue to look at other sources, though.
often keep coming back to housing and the fact that we have this housing crisis in this community where perhaps the marginal properties that weren't occupied 4 or 5 years ago, they don't exist any longer. For the most part, every dwelling is occupied in this community. People being exposed to homes that maybe aren't as well maintained as in the past.
Well, as well as, we often talk, and I don't want to dominate the conversation, but in my mind, when Matthew talks about heat mapping or what have you, if we were to do a housing inventory and identify the risk properties by the age of the property, some of those over time have been probably fully remediated. So how do we track that? If we say there's 1,000 trees, but only 500 may need some level of remediation, how do we keep the number going down and understand that? I'm not sure that we have that in place either.
So in Grand Rapids, actually, we keep an inventory of every property, a registry, a lead-safe housing registry. So all the properties that have come through our program actually are identified, and we continue to keep that on the registry. And then we can tell if somebody comes back in later and says they filed, they think it's at that property, and then we would know whether or not something showed up again after the work had been done over time.
And that might be a best practice to include in our report for all communities to consider. I'm not sure what other best practices are out there.
Connie, is that remediate, if I may, is the remediation permanent, or close to permanent, are we, when we put them on this registry, or are
Well,
we expecting in a short
So
period of
the
time?
property had tested positive for lead.
Mhm.
So improvements were made to deal with the lead at that time,
Mhm.
right? But that doesn't mean that over time, there might not be new exposure from the wear and tear on the property and everything else.
I see.
Because you can't, I don't want to get into the details because I'm going to get myself in trouble because I'm not the lead expert.
Mhm.
But there's only so many things that you can do without totally redoing the property. There's encapsulation, there's various levels that you're going through. And that's why it's really important. Typically, we do windows and siding because those are things that over time, if you're just painting and encapsulating and sealing, can wear, and that dust can come back. It can also be on the exterior in terms of the soil and things that are coming back into the house. So there's some of that. But no, we don't go back out and say, this has been on the registry. We did this 10 years ago, so test it now. But it does give us the ability, one, for anybody who's looking, and especially if you're a renter, to have the opportunity. We encourage you to go see if your property appeared on that list, right? So did it have work that was done, and you would know that. And then if something came up again and another child was poisoned, we typically would know that we've been in that property.
Now, is there anything for, homeowners that they need to have their house tested before they would sell it? I know there's a waiver that they would need to sign, but there's nothing on the registry regarding that?
No,
No.
yeah. We don't get into real estate transactions.
So I guess I will ask a bigger overarching question, and I've kind of asked it before. What's the intent of this report that we're doing? Are we gonna write a nice report? I guess one of the things that are like, this is all interesting, and we'll put it in a nice binder and we'll put it up. Or are we gonna have something that's in here that will provide like flow chart to use to, that we'd like all people to implement? Like, for example, in the state, it recommends that children are all tested at X months and X months. And that we would say that this should happen, and if it's negative, good. If it's positive, these are the next steps. And then we get it to all the physicians in Kent County, and we say, we expect this to happen. Now, granted, not all kids go to see a doctor. So then we'd have another part of the report that says, what are the proactive steps that as a county and as municipalities we should be taking? Is it that we have a list of what the risk factors are for homes, and before a home is sold, there's a checklist that we go through, and that we give the homeowners a list saying, you need to have these tests done. It would be helpful for you to do. What are we giving to our citizens and to our municipalities to say, here's what's gonna make our lives better? What are the to-dos?
Well, I think, we need to provide some recommendations, and, I don't think it needs to be in a glossy folder on a shelf. It's something that should be useful to the community. It's something that, should be used to inform parents and pediatricians, even, educators, home builders, and people that are gonna fix up their own houses on, this is what happens if, someone's exposed to lead, and give, steps they can take to, to repair and to, move on and, fix it up, the resources that we have in the community. So I do like the idea too of like a flow chart. If, a child is test positive, this is what needs to happen. But you're right, they do need to go to the doctor first. But having parents understand, this is what lead exposure looks like. This is what could be in your home. But how do you convey that to the community? We need to find the right community members to connect with, I think, and get the information to them.
And the right insertion points. Where are these insertion points? Because
Right.
again, we can make all these recommendations, but if they're not going to the right spot.
Mhm.
So I think that part of it is to identify where would be the best points to have these.
Right.
Is it every time you sell a house? I don't sell houses, so every time you sell a house, you have to go through this through the city or county, and so at this point, the homeowner is handed this and told, this is what you should be doing as far as lead abatement goes or lead testing goes. As far as reaching out to the physicians to make sure that every physician is given this and that it's a part of the standard process. I just think that we should be a little bit more rigorous around what our recommendations are, because we can have really great recommendations on paper, but if we're not getting them to the right touch points, good recommendations on paper.
I think that what's good about this process is that we get to create whatever it is that we want. So as we're having this discussion, we can format the report to include what it is that we're trying to accomplish. I think that it would be good as we create recommendations to create them by category. So if we want to have this health category so that it will then go to pediatricians or families, then we have recommendations that may term, long-term, whatever, however we would break those down, then municipalities, et cetera. Then we can categorize those recommendations so that they're not just this one long big list, but if I'm this type of person, I may be interested in this as a parent, I'll go here and there are some things that I may need to know as a parent. But if I'm a realtor, there may be a category for me to know as a realtor, and I can go there and look at those things too. But because I think if it's too many like this, you're not going to have people really looking at it, to your point. But if you narrow the categories down, I think, and whatever we come up with those categories, I think people will be more likely to take a look at it. And then I think it'll also help with disseminating the information. So how do you succinctly tell this audience this story about lead in the community, and then they can digest it and do whatever it is that they would want. And then I think the other piece is going to be accountability. So after we've created a report, and we have recommendations, then who's going to follow up to make sure that on a regular basis there's some type of engagement with the recommendations to make sure that those recommendations are being implemented throughout the county.
Did you have something, Jim?
If I could take the conversation in a little different direction, one thing that kind of sticks in my mind, a lot of the data that we've seen, or at least my impression of it, is that it's very, and probably rightly so, on the urban core. But I didn't feel that we had a good data representation outside the urban core. And that is where the problem has been identified. But I wonder if there's other issues out there that are less magnified because the data isn't as rich. So that's something that I would like to see going forward. I think if I recall correctly, testing is more standardized within Grand Rapids zip codes, but not necessarily outside of that area. So how do we know about children in Lowell, Rockford, Cedar Springs, where they do have older homes, maybe exposed to the exact same issues, but the testing may not be as frequent there. So that's one observation I had that I would like to see going forward. The other one, completely different direction, is we do need to keep perspective that a lot of what we have been doing seems to be working. If you look historically, and I know we have the more recent blip where we've taken a step backward, but overall, you go back, basically my lifetime, our reduction is tremendous. And if you step it out 40 years, we've done a great job reducing it. So how do we keep that pattern going? So we need to keep that in mind too. We're getting down to really getting to the low-hanging fruit's gone. We're getting to the tougher stuff to deal with. So we got to keep that in mind too, not get discouraged when we can't bring that number down on an annual basis because we've brought it down tremendously in the last 40 years.
Yeah, I definitely think it's important to keep that in perspective, just, 10 years ago, what the levels were at compared to now. But we still have to figure out, well, why was there this, increase? What changed in our communities? What's going on? So I think, that goes back to your question too, what exactly happened. But I do think, it has something to do with the movement in the housing market and people fixing up their houses and this economy. So.
Adam, is the health department further research on trying to get to the answer of the why there?
We have the data from the WIC clinic and our testing. That's about as far as we've gone with research. Research is always tough and expensive and cumbersome, and without real good hypotheses and data to go by, it's hard to do that. I mean, we've had a few different thoughts in mind, one being the market for real estate right now, the other perhaps was even the weather. In a dry or dusty or year, even a dry, dusty month could have caused that spike. And to Cameron's point, I think it probably would be wise in our report to reflect the history and the progress that we've made with lead in our community. While we have a problem, it really is one of the public health victories of the past. Victory might be too strong a word. Public health progress. It's not time to spike the football on lead yet, but we've come an awful long ways from 50% of our children having what we would now consider to be elevated blood lead to where we're at now. And the other issue that I think is really important for us to address is water. That's what really brought us here, was the issue with water in Flint in the past couple of years and the spike that we had here in Kent County and in a handful of other areas around the state. And I hear it at meetings, and whenever I go out in public, people talk about lead and they're concerned with their water. Is the water safe to drink? And I think we have put that issue to rest, that the water supply, anyway, here in our Kent County community, is not a problem. There are isolated problems in isolated spots, and in particular with fixtures and plumbing that a home may have. And I think we probably should make sure that we have best practices and things to look for and to do in order to identify those problems in your home. But I think we also need to make sure that we address the fact that our water supply system, as regards to lead, is very, very sound.
How did you propose addressing Cameron's point about identifying the data in communities like Lowell, who has particularly the older housing stock, or the Cedar Springs? Are you doing data sets there? Are there data sets that we can identify there?
So I've actually done a little work on that with my team, looking at out-county age of housing stock and how many units there are per jurisdiction that are 1970s. Every decennial census they keep track of that. So there is a source that you can draw that down on. So we can do a calculation of a percentage of the housing stock in Lowell that's older than our 1970. So we have some way to quantify it as a percentage and as an actual number.
I can't think of any reason why a city or a village with an older downtown area wouldn't have the same sorts of lead exposures that our urban areas here in Grand Rapids would have. So yeah, I do think we want to make sure that our report and recommendations probably aren't too metro-centric, but that they do speak to the whole.
So, following up to that, do we have an idea what the housing stock in general in Kent County is? Pre-1978, it's got to be the majority, the vast majority.
Mm-hmm.
We'd have to run the numbers, but I was surprised at when you take out Wyoming and you take out Grand Rapids.
What about East Grand Rapids? Most of that was
Right.
built.
No, I'm not, but I was looking at the data just in terms of sheer quantity of houses that were built, and you take out, because I was looking in our region, there's been so much new construction as a percentage after 1978 that there wasn't, I don't know. I'd have to rerun the numbers to get them on the tip of my tongue, but it wasn't to me like overwhelmed with the number of units that like was worried about.
I mean, I represent a part of Plainfield
Right.
Township that all was built before 1978. From 4 Mile to Jupiter and Plainfield to the river, it's all post-World War II construction.
Yeah. If you go to or one of the things I've come to understand though, and I forget which person reported it, but like the amount of lead in the paint, and 1960, 1965, they started phasing out different amounts of lead. So that's housing units before then were like the ripe, the most ripe for having lead in the paint. Doesn't mean those between 1960 and 1977 don't have it. It's just so because we were trying to quantify the number, like how many units are there out there that we could even have to address. Because Connie and I at one point were talking about like grants that HUD has, and she made a great point to me that it doesn't help our region to try to bring in more money for Kent County to try to enter the pool and to get a lead grant itself, because we'll end up competing with the city of Grand Rapids and their application. What's better is to work together and try to put that application in. So I can work with Adam and his team to do the geocoding of all this, because we can get maps out, I think, fairly easily.
I wish I had my laptop here. The U.S. Department of Housing and Urban Development has
They do have those, huh?
they issued a report that talks about the prevalence by region, upper Midwest, of lead hazards by housing age. And then you could take those numbers, and you're assuming that we're typical upper Midwest, which I don't think there's any reason not to, but there could be some discrepancy there. And we goes to Kent County housing stock to kind of see where risk is greatest and what kind of numbers we might project for housing to have. And you could do that by sub-municipality, but Matthew
And
is
that's
right
what
that,
we've used in the past to create applications for
yeah,
programs.
so like HUD's driving us towards pre-1950 housing for a specific reason because the incidence is significantly greater
So
there.
that's a big difference, pre-1950 versus pre-1970.
Yeah, so all of a sudden, your district changes, right?
Oh, yeah.
The risk changes, yeah. They're not exclusively there,
Right.
and that's the balance, the challenge here is that, HUD's also, pushing us towards secondary prevention, not primary prevention. So when we talk about going to primary prevention, we have to wrestle with that. But I have some of those numbers, and we also have some of the data by, and I'll have to look, it may be a little bit dated by, it might be by zip code or census tract or municipality of how many kids were tested by that area, and then also how many of them tested high. And so we'll try to share some of that information. I'll look for what's most recent. Michigan Department of Community Health used to compile this information pretty frequently, used to compile it upon request, but since the water crisis, their staffing situation is a little bit different for a number of reasons, and so it's a little harder to get that stuff real time.
Yeah, I think that may be one of the practical recommendations we have also is encouraging all of our pediatricians to make sure that they're using the screening tool for deciding when to test children for lead. One of the things that we have heard is that some of the pediatricians not in the core urban area maybe don't have as much of a sense of urgency or importance with lead. And so perhaps families in places like Lowell or in Rockford, are practitioners viewing lead as seriously in those areas as they do in 49507? That would certainly be something for us to remind them.
That's why the state's report goes towards universal testing. This is partly misunderstood, and AAP already had the Michigan chapter of the Academy of Pediatrics responded negatively to it. The folks putting this report together said we need to do this for a public health reason, not for individual health reason, not for this child, that child, and that child. We need to do it so we understand what the situation is and that becomes a little bit challenging. So, but that's why they're asking for universal testing, so we can really answer the question that Cameron's asking.
And I think even though obviously you want to look at right now most of our solution resources are secondary, right?
Right.
But I think in terms of some of the situations that we were just talking about in other communities where, maybe they don't necessarily have a volume of housing stock that would be predominantly affected by this, but yet it seems like the education and outreach to the pediatric community, doctors in those communities to make sure that testing is occurring, because then you have perhaps fewer cases but isolated cases, and then the housing can be addressed as well. So maybe as part of that outreach, it's really aimed where it's not the urban core where we know there's a mass of properties that are likely to be contaminated. It's different approaches based on sort of the look of the community.
I don't want to put the folks that serve on the county board of commissioners on the spot here, but it's my take that in part, I'm going to that. Following up on Mayor Seawold's question, what is the charge of this group? I mean, I think that where we can make recommendations that are actionable, that don't just sit on the shelf, are going to be recommendations that are in the domain of what the county has some kind of control over, right? I think it gets hard for us to make strong recommendations about how even though we have a representative here at our meetings about what the real estate community does. I mean, I think that gets very difficult. I think the kinds of recommendations we can make are the things that the county, and perhaps because we have two cities in a township here, what local government can also, I think that's about the extent of the recommendations that we can make and truly hope to see implementation on. We can talk about the other stuff, but I think we have to couch it in terms of what can we do? So if we talk about what pediatricians should do, probably should talk about it in relationship to what maybe the medical executive can, say about that, what his role is, and what kinds of support and resources does he have to try to influence those folks. So,
Well, I guess I would disagree to an extent. I'm not personally going to do it, but I could see that from us, our recommendations would be, or our directions would be that we want then the Kent County Health Department to create, and I'm just gonna make this stuff up right
Yeah.
now. We're gonna create a plastic card that goes to every physician office, and they can determine how to best do that. And on this card, it says, every child needs to have testing at this age. If they cannot afford it, if their insurance doesn't cover it, here are the things that they could do. On the back, if the results are this is what they need to do. Here are the next steps if they're positive. It's in every office, and the physicians know that this is an expectation. Then you go to the home market. I'm not gonna go to each and every house and say, your house is trouble and your house isn't trouble. I don't have enough time or money to do that. But wouldn't it be great if every time a home is sold, and again, I don't know at what point do you register a deed or whatever, when do you interface with your municipality, but that somebody gets a card that says, here are the risk factors for your home. If your home is older than 50 years old, it's X factor. If it's older than 20 years old, it's Y factor. So these are the risk factors, and what you should do. You should get lead testing on your windowsills and blah. And so, and this is average how much it costs. If you cannot afford it, here are some resources to go after. Why do you care about this? Because lead testing does this and this and this to children. Here are your options. And it's given to every person. It's up to them to do it or not, but it's given to every renter. I just feel like we can put actual tools into somebody's hand that they can look at and they can go forth with. And if you have a home that has, does not have turf around it, instead it has loose soil, that's a bigger risk factor, and so that's something you include in the card. If there's soil around there, you've got a bigger risk factor. So that people can then take the next steps and know why it's important and know what the next steps are, and if they can't afford it, what they can do. That would be real stuff that would come. We can have a report that's got all this, but if we have real deliverables that go to people that need them, that's what's gonna really help in the county. Those are real things. Otherwise, we'll just have another report. I got one. It's the state report.
I would largely agree with what you just said. I think we're coming from the same place. What can the county do within its domain to
Like I say, I'm not gonna
push
make
that
those
out?
do it.
You
We
can't-
can tell that, whatever in the county, this is your job and you need to create this.
Our logic can only extend so far, and we have to.
Right, if that was my job, that would be a fun thing to do. I would love to do that. Not my job.
And I love what you're saying also. I think whatever report we have has got to be actionable. It can't just be a big giant report. Because honestly, when I look at this, I have a hard time
And that's what I'm
consuming
talking
it.
about. There
Right.
needs to be actions on there, and those are the type of actions that I would like to see.
I think probably an important next step to getting there is getting our minds around what is currently available, what the resources are, so that we can start to build that sort of a system. And I think it goes also to Connie's point a little bit earlier, is probably need to start tackling that inventory assessment of what's out there now. Does that sound reasonable to everyone?
I don't know about you, I'd feel really cool if I was in my doctor's office and I saw that and I knew that I could help make that happen. Or somebody bought a house and they told me, oh, I gotta go get some lead testing. I help make that happen. That's important stuff.
The county does register the deeds every time there's a deed transaction.
Like, you can lead a horse to water, you can't make them drink, but if you handed out that material and explains it to them.
Which would help on the sale of a house, but I'm not sure about rental of a house.
You're supposed to disclose known hazards. I mean, that's already required.
I think actionable is the right term. I'd like to see actionable items on here that we then could follow up, we could have a timetable, we could follow up, were they done?
As Paul was, reading the report, he directed us to page 24, which is Untitled 10, and it's prior to becoming obligated to buy or rent, that information's given. And so that would be an easy one to just sort of reinvigorate and make sure it's being done. working with, you know, a realtor here in our local communities.
She's not here today.
I know she's not here today, but I mean, it's apparently something that was
It's like a
1992.
disclosure, it's like a disclosure form, so it isn't as robust as, you know, because of this age, this is what you should do, but I
That's-
think
it's
it's
a-
a
it's a
really,
different-
how do you add to that existing disclosure form
Well,
to
and-
create something more tangible?
When you're, you know, closing on your home, you're going through so many papers anyway.
Yes.
So if that's, you know, one more thing that you're not really paying close
Right.
attention.
No,
That's
Well,
gonna be a
this-
file
This
that's-
says prior to
And that's why
becoming
this is gonna be a
obligated,
pretty thing with
Right.
cute pictures on
so
it.
it's not the end.
Right.
And a free ice cream cone with attached to it.
Yeah.
Well, I think, though, partnerships are important. So when you think about the medical society or the osteopathic society, right, like, getting them to buy into these recommendations now, whatever they might be, or engaging them now, to say, this is where we're thinking, what do you think? And helping them to self-regulate themselves and the buy-in to this universal screening and the why. And then where do you send the data to, right? Like, this is one of the things that's so tricky, because we have a number of payers in health insurance, is that oftentimes the data is in different data sets, but it's never brought together, which is why we often use Medicaid data. But to Cameron's point, the number of people on Medicaid isn't the same, maybe out county as a coverage as it is in a core area. So we don't see how many elevated blood levels, and we don't know how much testing is going on because we don't have the data. So I just think that that part of that engagement strategy has got to, we've got to think a little bit more about how to do that appropriately, because that's hard work to get the right people that want to own it and want to buy it, and just don't say, I don't have time, you know.
Yeah.
And but yeah, I'll leave it at that.
I think it's a really good point, Matthew, and I wonder if maybe in a future meeting, as we're talking about possible recommendations, or even the meeting where we may have people to come to talk about what's happening currently, if we can invite targeted audiences to, even if they're just listening in, like the RPOA, they're the Rental Property Owners Association. If we're talking about rental properties and the fact that they, you know, may be high in lead, they may have some input on the process that will never get touched in this transaction between homeowners. And so, you know, how do they then become engaged? Because there may be some expenses that they may have to incur based on recommendations, and it would be great for them to be a part of either A, knowing that these discussions are happening, or B, maybe potentially providing some input so that we can have recommendations or solutions that they would possibly, you know, embrace, even if it costs them more money, because, you know, the outcome of it would be the reduction of lead. But that's just one group. You know, there are many other groups like the pediatricians, et cetera, that could potentially weigh in on that and may find it beneficial.
That's, it's a good suggestion. You know, the RPOA has been a longstanding partner for the City of Grand Rapids lead program, along with Healthy Homes Coalition. So, and they've done a lot of work in terms of outreach in other areas with that particular program, and have always been sort of played a key role in our implementation of our projects, so that I'm sure that Clay would be more than happy to provide feedback and input.
We had also talked about doing a survey, and maybe that's another way of getting some input from potential stakeholders, and surveying them to see what their thoughts are. I don't know where we are with that. That's one meeting.
No, that
It could have all
that was the
happened.
important.
It all happened
So
there.
I think it would be good for us to figure out what are those access points that we want to really focus on. We talked about the rental property owners, pediatricians, realtors, building departments because they're giving out renovation and new building permits, that sort of thing. Maybe schools. What are some other ones that jump to mind that we want to engage in this conversation?
Parents, I don't know how, but, you know, and they're different from the pediatrician, because there are parents who take ownership of their children's health and may demand or ask, you know, for things to happen at the doctor's office that the physician may not on their own suggest. So, and that's our obvious, large category of people, but I think that somehow we need to figure out how to educate parents on this.
Would you target the areas right now that, you know, like 49507 currently high and start there with the parents?
I don't want to answer that
Focus.
because I would seem biased. But I think to Cameron's point, you know, if there may
Yeah.
be other high zip codes. And
Right.
so maybe the solution is really high zip codes. So which obviously would include 49507.
And I don't want my comments to discredit the fact that we've identified hotspots already.
No.
And we certainly should target those.
But I think that if we only target those and there could be other hot spots, then we're missing. I appreciate your sharing that. So, but yeah, that may be a really good way of narrowing parents down to maybe hot spots.
What are the other zip codes other than 07?
I don't know.
Top three are,
You would know.
regionally are 703 and 04. So.
I live in 03 and I grew up in 07.
Yeah. Well, it's kind of a weird one, yeah. So, yeah. The other thing in terms of parents is, we just know that there's a very high prevalence amongst the Medicaid population, so poverty has something to do with this. So talking about it, we probably ought to engage parents who have financial constraints, because that seems to be a driver.
But like parents that their kids may participate in like Bright Beginnings or, you know, a program like that where they're already getting some home services,
highest
there
307.
may be some correlation.
But see, in my mind, I think about that and I think those parents are less likely to be parents who aren't getting testing. Because there are other factors that draw from the health department, for example, into testing their kids, or Medicaid, for example. But it's a parent that may live in those same zip codes who may not have access to Medicaid, or who may not tap into any of the low poverty type of programming, who may not know that their children are at risk. And they would totally be missed if we try and narrow, you know, hone in on those children who are already on the radar of other organizations. They're in poverty.
It's not necessarily, you know, educators that we should go after either, because most of these children are, you know, preschool age, so.
And even, you know, there are a number of free preschool programs
Right.
for people who are low income. So those kids, again, will be, you know, a part of a population where they'll be tapped into. The kids who don't attend preschool are probably from families who don't necessarily send their kids to free preschool programs.
So the one thing that most parents have in common is their kids go to school.
Yep.
So would KISD be a good one to bring into this?
Well, we said before that when kids enter into school, it's too late.
Yeah.
So that's, now
Okay.
we're beyond
Right,
where we
that's a
need to
good
be.
point. We're putting it
Yeah, we need to be.
3-4 years back now.
Mhm.
So. Now the KISD wouldn't be a good one to also do, but you're
Sure.
right. How do we get upstream from?
You have to get to daycare.
Daycare
Care providers.
But
Does
might it
4C still exist? Does it still exist, 4C?
Still exists, yeah.
Okay.
Might it still be a valuable resource if, even if the child in the school is beyond that age, if there's younger siblings in the home,
Yeah.
there might be some value there, just as a conduit for getting information out.
This to me is like a traditional public health communication strategy that encompasses multimedia messages linked back to some kind of data platform on a website or something with videos that you can teach people about lead and best practices. It also then seems to me to need this targeted effect of you have certain populations where you know you need to target messages for certain reasons, but you still have to embed that in a large campaign.
There needs to be thoughtful language.
Right, and all those things. I know that there's a lot of work going on right now to think through, like, how do we do a large chronic absenteeism push across the whole county, and then follow that up with targeted interventions at certain spots where we know there's hot spots and issues. So you've got to have the broad message so that people understand it, but then also the secondary follow-up that's more detailed.
You know, if we're really looking at early age, right? Most babies are born in hospitals, not all, but most. And nearly every hospital who has a maternity ward has little bags that they give. One if you're breastfeeding and one if you're formula feeding, because they have different little goodies in the bags. And it seems like if we put together a very nice educational piece, that would be a prime spot. And also if there was the actual medical community in terms of the support they're giving mothers leave the hospital, that education in terms of the importance of testing and at what age and what have you. To me, you know, you got them in their first hour to 3 days, however long they let you stay.
It's like 1.5 days.
Yeah, I don't know how long they stay.
It's not long.
I had one that didn't even get to stay 24 hours. We had to go back, so they kicked us out.
That's a really good idea. They also have videos, you know, so you can do PSAs or something that are shown in the room.
I don't know how close you're paying attention to those as a new hire in some cases.
So even getting upstream from there,
Early classes.
OBGYNs.
Right.
Mhm.
Yeah, and also, you know, we've got programs, this gets to the Medicaid and low income.
Once it happens.
The MIHP program and the nursing partnership program that work with low incomes and high risk moms to be.
So,
that,
model program already going on in the health department where we've done a retiree rehire that has deep experience in lead going out with all the MIHP home visitors, all the families participating in that are willing to accept her. She's coming out and doing a primary prevention message right there. I think sustaining something like that and building on it is a very actionable thing that we can do. There's not just MIHP, there's other home visitation programs like Strong Beginnings and other groups that have reached as well. You could take that again to the early childhood education, the pre-K education opportunities. Again, we're getting a little bit late, 3 and 4 year olds, but there's the groups through Head Start, through Great Start at the ISD, as well as what Dr. Eza and ELNC are doing for the kids who aren't participating in those programs that Commissioner Lanier talked about, that are opting out, and how they're reaching out to those families specifically. There's another opportunity just replicating on with MIHP and just building upon this current program that seems to be working.
I'll just get to Cameron's point again about Out County. MIHP is a targeted group of Medicaid residents, right? So,
But Great Start's not.
no, I'm not disagreeing with that, but I'm just saying, like, we have to, I think, you know, in that vein, but we also have to look at the housing stock issue that, you know, we talked about earlier, and that larger communication level. Because if you don't, you're going to inevitably miss certain population groups when, you know, and frankly, we in government have much more access to that lower income data through the Medicaid program or the data sets. Because it is government funded, the data comes through to us in different subsets than private health insurance or private, construction or things like that. So, you know, one of the things I thought about in this big data mapping that we might want to try to figure out is like building permits pulled. You know, where are the building permits being pulled at when we see these elevated blood levels, and can you overlay there and find a correlation? It talks about safe practices of lead exposure, right? Like, are you sanding your house down to paint it? Are you doing something different? Like, it may be a long shot, right? Who knows? I'm just picking, but that's the kind of ways that you can start to look at where are those potential correlations that you might not have easy access to the data about. Just a random thought.
I think, Matthew, where we find probably the biggest error for exposure are painting, right? Exterior painting in particular, interior, we don't really have control of, and you don't need a building permit. So, while permits might be a good tool for some things, I'm not sure for the paint that it really is. And I think that's what we see the most. In our code, we actually have, in our housing code, we consider it an immediate hazard for peeling paint. Now, we don't do proactive testing but if we get a report that there's a house with peeling paint, then we presume it to be hazardous.
I wonder if there are any effective models or examples out there where communities partnered with their local hardware stores with
I
some
was thinking
sort
Home
of,
Depot.
yeah, some sort of memory, something that would trigger a thought in someone's mind as they're buying their paint and their scrapers and all that stuff to do things about lead.
So Adam, at the health department, if our recommendation, because, you know, again, I am not gonna create these. Is that something that our deliverable from here can be, we would like to have, and I don't know if I'm just volunteering an organization that doesn't do it, the county health department will create deliverables that will, in a plan to get these materials out to, you know, as many physicians, mothers, homeowners as possible, and they can report back to us how they're doing it. I don't know that it's my job to actually create that plan. What I'm saying is I'd like there to be a plan. If this was my full-time job, I'd put together a really good plan.
Yeah, so.
And really good materials.
So health education is a component of what we do, along with community communications is also a major part of what we do. So as far as creating documents or cards or that kind of thing, then having a game plan and following through to distribute it and maybe to do some trainings for people so they know what they're getting and how to use it, that would be within our ability.
Yeah, and that's what I think we need as a committee. That's what we need to say, that's our deliverable, is that we would like to see this come from our health department and that come from this, you know, again, we're not gonna create them, we're not gonna come up with every idea here. You've got some great people that are gonna come up with those ideas, but that's what we'd like to see.
I think, if I could respectfully disagree, I think that the value of having people from different sectors at this table is going to provide, not that your staff wouldn't come up with these creative things, but I just think just having a different lens, participating in the discussion will allow us to come up with a maybe more comprehensive form of recommendations. Now, what happens with those recommendations afterwards, maybe it does land with the health department, but I wouldn't want to, after spending this much time here, delegate the plan creation to any one entity, health department or any other entity at this table, because I think there's value in having the perspectives that, even to the piece about, you know, thinking about having not heard from some of the surrounding communities is a really good, valuable piece that we really hadn't thought about. And so I think that there's value in having the diverse voices and sectors here at the table.
I'm not saying the voices we shouldn't have the voices, but we're not doing the plan. I mean, not the plan, we're not making the materials, we are not doing the rollout, we are not. So they could bring it to us, here's our rollout, here's what we want to do. This is what we've put together. That would be great. But I'm just trying to be realistic. I'm not going to be creating these materials, and I'm not going to be going through and making sure that the deliverable is the way I like it to look.
But I think, Matthew, you had said something about a campaign of sorts, and I've been thinking about that, and I wondered, now this may be something that we can't to do, but I wonder if there's a way to have this broader campaign that allows people to opt into their own testing situation, but I don't know if we have the capacity. So, you know, if there's some campaign talking about how old your home needs to be, and I live in one of those homes, how do I get my own self-testing kit, or where do I go to get that? So as we're thinking about a plan, I think we also need to think about the capacity of they provide whatever it is that we're suggesting people go after. But I think that would be good if we had this broader campaign, and if I knew the age of my home, or even if I didn't off the top of my head, maybe I'd go and research. If I learned through this billboard, for example, that, you know, my toddler, which I don't have one, but could be exposed. So I'd probably do a little bit more research based on that.
Or if your house was built before 50, you know that, maybe you wanna go spend a few dollars to find out
To
how your
find
pipes
out.
are doing and how your lead is.
Right.
If you could do some self-tests and there's some kits available from the county, I'd probably do that in my own house and pay for it, just so I have
Right.
an understanding of what I have. And if it's something I have to deal with, I can deal with it.
Right. And where do we get that, you know, how do we build that system and where do we send people to in
Right.
order to get that, I think is part of the capacity question.
And I think that would be something, you know, partner with stores and helping educate, whether it's a big box store or a local.
I think the, sort of the venues for public education and outreach are almost endless on this topic. So, you know, putting together though the strategy of what's the right starting place and how broad do you go and where do you focus? Because even though you might have great outreach materials, that all costs money.
Mm-hmm.
And resources, so, you know, a plan is
Get a
really
return on
important.
investment.
Yeah, but I hear the county has tons of money, so.
We all do. We all think that.
Oh, it's
So maybe
so
part of
funny
it's-
how that always gets brought
Matt
up.
already-
Just called cash flow,
It
the
always comes-
state makes us, you know, they don't let us collect our property taxes till September. It's pretty amazing like that, how it works.
I'm sorry.
It's all right.
I didn't,
You know, there are
you
some.
know it was all in fun.
To that point, Connie, I agree with you. There are also a
Just
lot of
spend less.
opportunities in this community that don't cost an awful lot.
Right, but that's why plan
Yeah.
is what's
And so
important.
we found out with our flu campaign for this year, maybe you saw them on TV, the Take the Shot campaign with the Griffins. Did anyone see that? Okay.
I did.
Well, so we created that video, and the Griffins happily, they were more than happy to help us with that. And so here, that automatically brought some appeal and some glossiness to that campaign. And then we found out, we originally created showing on the Jumbotron during intermission. Well, we found out that the TV stations here locally, they need, because of their licensing, to do PSA stuff, and they gobbled that up, and they broadcast those, and we thought maybe they'd be on at 2, 3 o'clock in the morning. My goodness, they were showing it, they were on, like during sporting events, football games, you know, they were putting them up there. So there are opportunities like that. If we have a really concise message on lead, it wouldn't surprise me a bit. If we could create something like that, it would get that kind of.
And the key to that then to me is like the link back to a website that is low, not low cost so much, but gives you all kinds of great links to resources. And so if we talk about like how you dissect recommendations for medical, construction, housing, testing, and I'm sure that, you know, the EPA and other places have put out like best practices with little video things that you can build and bring in there. You know, that's that large public messaging that has to happen, and there's got to be that resource back, and then that's how you start to build like a campaign. It seems to me is like that was when I was at the Griffins game, that was a great deal. It was well done, and yeah.
I think going back to the previous conversation about how do you connect to people who maybe are not connected through some of the true low-income, you know, connectivity, it just hit me that maybe doing something with the Kent District Library and the Grand Rapids Public Library, because in the city of Wyoming at least, we've identified through some of our research that only approximately 30% of households have access to the internet. So when we talk about going to websites, there's a barrier still there in our overall greater community. In the one area that persons who are moderate income or Alice incomed, right, they make too much money but not enough, often turn to the libraries as resources.
What was that percentage, Rebecca?
30%.
That obviously isn't including the internet that they have on these things, right?
That's
Is it?
correct.
Okay.
That was when we were looking at traditional. Yeah, cell phones have taken it, but the data plans, again, typically if you're talking about those who, again, are maybe Alice enabled, probably are not going to be using their data time
For this.
for this.
That's right.
Just a thought. That's probably more for Facebook, right? I mean, the priority.
More important things.
Yes.
Yeah. Good point.
Any more thought, questions, directions? No?
I really appreciate what Connie said about, I think there's just a way to take this without getting into the weeds, take a large bite at it and say, a strategic communications plan needs to be developed and begin implementation. I mean, that's a way to, without getting into specifically how and who
Yes.
it's in place. So, and then the other piece that's haunting me is Gustavo's map and the big bubbles. The houses that have poisoned multiple kids, and we didn't talk today, but I can't forget those big dots on the map. And I'm personally familiar with one on Gold Avenue Northwest that's poisoned multiple kids. And we still don't have a way to stand in front of that particular problem. A lot of it's tied up in protected health information, but, that house continues to be the way it is. And because of current resources, we're not able to get in front of those properties.
Is it owned by an individual? Is it a rental property?
It's a rental property. It's a 2-unit, so it has twice the ability to poison kids.
And we know that, and there isn't anything we can do.
There's limited things that we can do. I mean, it's protected health information, that child's been poisoned there. Current resources don't allow us to pick on that one individual landlord any more than another. So we have policy about where we do environmental investigations, but those are limited to the highest poison kids. Kids that were poisoned in this property tended to be lower level exposures, but we're still north of 5. And so, it's still challenging to know how do we get out particular address, and others like it. So.
That's horrible.
But she was just saying you can't prove that they were
Well, I think
poisoned.
you have to also.
That's part of it. You're right. You have to do an
You can't-
investigation. So the first step is, in that property is somebody's got to pay somebody to go in there and look at it and say, is it reasonable to expect that it's coming from this property? And we don't have the resources to do that.
I think we can too.
That's not a code, but we can't prove that they were poisoned there, so we can't.
The
housing
property's certified.
code
It's a
doesn't-
certified rental property.
Right.
Meets
It meets
certification.
code in all other ways. We can't just go in and.
And no conversation with the landlord about it.
There may have been
Because that costs
conversation.
I don't know what property he's talking about, so
Okay.
I really don't want to say whether if the city of Grand Rapids inspections has, not done their job, because I'm not certain that's the case.
It was certified.
Okay.
So,
It was certified.
So how do you look at the certification requirements and change those? Would that be a way to go with this?
Well, the city's code is not a health
like-
code. It's a housing code.
right.
Two different things.
It's a minimum standard code. It's the International Property Maintenance Code. And then we actually have addendums to that code that go beyond what the IPMC, which is what most communities have. In fact, we have some specific items that we think is stronger than what's in the IPMC. But that is a minimum code for health and safety.
Probably a year-old.
I don't know until I talk to Paul after the meeting to find out what the address is. I'm not sure.
Snow in the street.
I think it's just a point, is that there's an example of, like, there are certain places we probably know about, right? And like, what I hear, the question being asked in general is like, do we have all the tools we really need or can actually, have available to us to handle situations like that?
We don't.
And there's that value, and the tension on the other one is personal responsibility and, as a property owner, as a landlord or whatever, and how do you balance that? I mean, I don't know where that line is.
I guess I will say, this came, led board examples, the same types of things in Detroit. I mean, so this is not unique to Grand Rapids by any stretch of the imagination.
Sure.
It's happening in Buffalo, New York, Baltimore, Maryland, you name it.
Do you recall how many of those there were in his map?
Big dots, no, but we should take a look back at that. Quite a few. He had 6 years of data, so.
Any more questions, thoughts? All right, well, is there any miscellaneous off-topic items? No? I think we have a lot of we had a good discussion today, a lot of good thoughts and questions. And, I think that kind of leads us to our next topics at future meetings. I'd like to hear more about what resources we do have available, and maybe you have a couple people in mind for that, the city or, in the area. And then, hopefully we'll be able to hear from Lieutenant Governor Cali too, from the state's perspective. And so I see, things are kind of lining up, and we'll have a pretty good list of recommendations, and I'd love to be able to follow it up with, something that we can pass to the community and say, this is what, we should do, and let's, reduce the flood levels even lower. So thanks for your input today. Our next meeting will be on June 20th, right here in this room at 1 o'clock. So look forward to seeing you all again.
What's the topic at the June meeting? I don't have my chart with me.
So I think we're going to focus on local interventions.
Okay.
Because if we have Lieutenant Governor Cali coming in July,
July.
that gives us next month, so we've got a month, we can start pulling that list together. We can get 2 or 3 good speakers, and I'll work with you, Connie, on that. And we can get that set up for next month.
Okay, great.
Sounds good. Thank you.
Thank you.
We're adjourned.